Good evening. Thank you very much for providing me a podium to present our work in spine surgery at Shalby Hospital. Basically, my role today is to introduce our department, what we call is a Shalby Safe Spine Surgery unit. Okay. Will not take much of your time. I'll just try to finish as quick lecture. So I'm standing between you and him. So we'll try to finish as fast as I can. So this is my team. We work with 4 surgeons and 1 specialist physiotherapist in Department of Spine Surgery. What has changed in spine surgery since past? First of all, it's the youngest offspring of orthopedics. We know today that it's whatever we know is still a tip of iceberg. This major of part is still a submerged part. It has become from being a part-time expertise of ortho or neurosurgeon, it has become a specialized branch of experts, from a doomed specialty to a result-oriented surgical branch. When we compare to past, we better know today that what are the pain generators of spine, importance of various ingredients of spine that actually forms a spine, natural history of common disorders. We do know now today that by preserving what, we can give better results, and by damaging what, we can actually compromise on results. We have better technologies to support and better technical expertise to use those technologies. We call our spine surgery unit at Shalby a safe spine surgery unit because we have made spine surgery much safer than it was before. So what is composed of safe spine surgery? First of all, it's a specialist spine surgeon. Surgery, what we perform, it's with always a minimal invasive technology. We use probably the best possible equipment and infrastructure to perform these surgeries. We have dedicated OT and a dedicated OT staff to minimize human error, because same persons doing same thing at the same place actually reduces the chance of human error. We have ultra modern operation theatre, and we always utilize an aggressive rehabilitation approach in spine. Our patient starts walking within 4 to 5 hours of surgery, and most of them are back to their normal activities within 1 week to 10 days time. So what are the equipments what we have started using? First and foremost, all surgeries are microscopic surgeries. We have entire array of instruments that we utilize for minimal access surgical technology. We use endoscope for local anesthesia surgeries like percutaneous endoscopic surgeries. We have a navigation for revisions cases, what Dr. Pachori already mentioned, that we are being a tertiary or quaternary care center. We are getting more and more revision cases, and navigation actually helps us to perform these surgeries much better. We utilize this neuromonitoring so that our surgery becomes safe. We don't damage the most vital structure of spine. Intraoperative surgical monitoring. We'll just quickly take you through a couple of cases so that I finish fast. Today, instead of performing disc surgeries from a large hole, we started using disc surgeries from performing this tubes. You can see this African gentleman whose spine was 90 mm deep. It is impossible to do this surgery from 1-inch cut with traditional retractor systems or opening surgery. We did with 1-inch cut from 90 mm tube. This is 18 mm diameter surgery, and a disc surgery was performed. Cervical spine surgery, we see day in, day out, cervical disc herniation. Patient comes, the traditional surgery has been the fusion of anterior structure. A lot of complications. You can have recurrent laryngeal nerve palsy, you can have fusion problem, you can have implant related problem. With minimal access technology, we can do this surgery from again 18 mm tube posteriorly, preserving all vital structures anterior from just 1 centimeter hole, and this is out. Patient actually can go home within 24 hours of surgery. We receive this kind of down-migrated disc herniation, and we have expertise to perform this surgery under local anesthesia from as tiny wound as 2 to 3 mm or 4 mm cut under endoscope. Patient actually can walk out of your operation theatre immediately after surgery, and this surgery is possible from arrays of endoscope what we have at Shalby. L4-5 lumbar canal stenosis, a classical symptom presentation of older generation. A traditional approach has been fusion, and if we are doing from an open surgery, probably it requires a long incision, long stay, long rehabilitation, and we can do from just 1-inch cut of incision and another small incisions to put these screws inside. This kind of compression fracture in elderly patient, We can do this surgery again under local anesthesia without utilizing any anesthetist, from as tiny hole as this possible, a blood dot, and patient doesn't even require a suture for this kind of surgeries. We can utilize this surgery from multi-level stenosis also. We are getting more and more adult deformity cases now, and we can do this surgery very safely because of our modern equipment which we are having. This kind of surgery is possible at our hospital. We get this kind of trauma, a completely dislocated spine with normal neurology, and we can perform this with our neuromonitoring and navigation system. We get this kind of deformity patients also, and with our best infrastructure, we can do this kind of correction in child also much safely. So minimal invasive surgery is the future of spine, and it's going to stay. However, scope and usefulness of conventional open surgery cannot be underrated. Thank you very much.